So with switching gears from BPH to prostate cancer, there's a lot of overlap, but you want to know what's different, right? So what is different is, well, it's the most common cancer in men. Obviously, it's not going to be the most common cancer in men and women, and but it's diagnosed every 3 minutes. People die from it every 16 minutes. It can be discovered late because we mentioned that it grows in the peripheral zones, the glandular tissues around the prostate, or around the urethra. So this little transitional zone right here, that was BPH, right? That's where BPH grew and it occluded the urinary outflow, and we get what kind of symptoms? Raise your hand. All right, you look like a crush person, all right? So yeah, so it's going to cause storage issues, and what symptoms are those? What symptoms are those? Storage issues. Funny? All right, there you go, pass it back. All right, so you get funny symptoms, right? And what does funny stand for? And incontinence. Good. All right, so if you want another drink, there's 2 drinks there. All right, so 81% are localized on diagnosis, but there's some that will be growing in the tissue over here anteriorly, right? When we do a DRE, we're assessing the back half of the prostate, right? You can't get around and poke through the rectum and go around to assess the front of the prostate, right? So a lot of them grow anteriorly, or about 20% of them grow anteriorly compared to the ones that we can detect on a DRE, a digital rectal exam, right? So the survival rate is great if we can localize it. So it's important we get DREs for that reason. We can detect BPH, which is okay. We'll watch it and see if your symptoms get worse. But prostate cancer, if it's bumpy, right, that is bad, and we need to start treatment as soon as possible. Okay, so cause is not very known. There's risk factors. Being older is the single greatest risk factor. BPH, though, is not a risk factor for this, right? And also STIs, right? Sexually transmitted infections are also not. Right? Like I said, with ulcerative colitis, you got all this chronic inflammation. You'd think that would that leads to colon cancer. Why doesn't chronic inflammation of the prostate lead to prostate cancer? It doesn't, right? Statistically, it does not, right? The last guidelines came out in 2014, and this is what they found, that what puts you at increased risk are being overweight, right? But the World Health Organization, again, does not mess around. They say body fatness, right? If you got body fat, you are at risk for prostate cancer, right? Consuming calcium and dairy puts you at high risk for prostate cancer as well, right? And selenium, where do you get selenium from? Brazil nuts, good. Yeah, so Brazil nuts. All right, you deserve a crush or a cranberry juice. What would you prefer? Cranberry juice for your UTI symptoms. All right, so yeah, so they have a selenium found in Brazil nuts, but again, just take any kind of multivitamin, that's going to be cover you. Okay. All right, so prevention. So there's things that are not proven. Lycopene, vitamin E, and such doesn't really show much. But what does work is ejaculating 21 times in a month. Not like at the end, like in one day, but just spread it out, right? So if it's November 27th right now, so you got 3 days, that's seven times for each day, right? All right. So, but November has another name to it. What's it called? Mm-hmm.
This is what actually happens when you do No Nut November, according to science. More wet dreams. Wet dreams or nocturnal emissions aren't always about sexual arousal. Nocturnal emissions are a way for the body to clear out old sperm. Your sperm has an expiration date, so if you haven't fired your gooey cannon in a while, your body gets rid of the old stuff while you sleep, so the sperm on tap is fresh. You're a sperm recycling factory. Any sperm that reach their sell-by date or aren't used up get broken down and reabsorbed by your body. This is especially important for men that have had vasectomies and their tubes cut because they still produce sperm. If your body didn't reabsorb unused sperm, your dingleberries would swell up like a dogfish's horns. You might be missing out on good quality sleep. After ejaculation, there's a rise in the level of prolactin. This hormone promotes rapid eye movement sleep. It also explains why some men fall asleep after horizontal bedroom wrist.
All right. So yeah. So it's science. Okay. So yeah. So prostate cancer is this guy right here. We have this overgrowth of tissue, glandular tissue, which grows in the periphery, and unfortunately, sometimes it does not grow where we can actually palpate it with a what kind of exam? With a DRE, okay? All right, so symptoms of prostate cancer, asymptomatic, unless it's so big that it's actually starting to compress things like this prostate cancer right here. Now it's starting to cause some storage issues, the whys and funny, right? Whys is your obstruction symptoms, funny is your storage problems. We have this overflow incontinence, it is frequency, urgency, because your body's like, pee, right? Why aren't you peeing? It's like, well, there's an obstruction in the way, right? There can be pain, especially with ejaculation, and it can metastasize, and that will cause pain. Metastasizes to the what? So bone, right, has breast, bronchus, bidney, and prostate, right? And multiple right? And besties, right? So anyways, or testicular cancer. Anyways, we have metastasis will cause back pain. That's a sign. Oh, why do you have back pain? And why do you have, flu-like symptoms and loss of weight, unintended weight loss? That's always a red flag for cancer, right? People say, oh, you look so thin, you look so good. It's like, I know, I've been doing nothing. Well, let me make a call, right? So, yeah, they might be malaise and fatigue, they have bone metastasis, that's not good, right? Also, the lymph nodes can get swollen and start compressing, like the ureters up top even. But it's usually mostly asymptomatic. So that makes sense, it's usually mostly. Anyways, it's asymptomatic a majority of the time, okay? So diagnostic tests are to screen, right? So they did we can do PSAs, but again, there's a lot of, the verdicts, they're not the verdict, but the statistics are out and say it's not really great that doing it like an elevated PSA means you have prostate cancer or even BPH. Yeah, BPH, it will be elevated, but like what is it really that shows that someone has cancer and they need to go get a biopsy, right? Because a biopsy is pretty involved. It's really painful, and there's not zero risk to get a biopsy, right? So really you have what's called a patient-directed conversation, or you have another way to say it, a shared decision-making to decide, hey, if you're 85 years old, your life expectancy is probably 94, 95 or so do we need to go through getting a huge biopsy or not, right? So we have to look at what symptoms they have and is it causing disruption of their normal life function, and then maybe we might consider doing biopsies. If they do a biopsy, it's 2 biopsies. It's not just one, right? It's like, oh shoot, just one. No, it's 2 biopsies, and you average the results, and then you get a grade. Remember, you have grades like tumor, node, and metastasis. Metastasis is easy; you can see it on a scan. But otherwise, for grade 1, 2, and 3, you have to assess, well, how much overgrowth is there? How much hyperplasia is there? Right? It's called a Gleason score, where they take 2 biopsies and they average the results, right? But PSA can elevate for other reasons. Did I put it on this slide or the next slide? Maybe I didn't speak about it last time when we talked about PSA. Let's see if it's coming up. But there's other consequences or other reasons why your PSA would be elevated. Is it coming up, or did I not talk about it? What's up? So there's other reasons. There's like bike riding can do it, right? So you're bike riding for an extended period of time, that could cause your PSA to go up. If you have anal sex, that can do it. All right, if you have recent prostatitis, that can do it as well. So overstimulation of the prostate can cause it to elevate the PSA. Okay. So what else? So DRE, right? So when they do a digital rectal exam, it will be bumpy, right? It should be smooth like what? Like an eraser, right? It should be the size of your thenar eminence, but that's really, we're talking about BPH, right? But if it's big and bumpy, that's obviously not good either. Okay, and again, we said if it's PSA is 4 to 10, then we have this little piece right here where it's like, is it free? Is there a lot of free PSA, or is there not so much free PSA, right? So in cancer, there's more bound PSA. There's not a lot of free PSA floating around. Okay, so biopsy is if we screen them and we saw, oh shoot, I see something bumpy, or I don't see it. You don't have that kind of vision, but you would feel something bumpy on the digital rectal exam, and that would then prompt us to consider, what do you want to do? Do you want to get the biopsy, or you're only 55 years old and your brother had it, your dad had it, you're overweight, you smoke, you have all these things? I think you should probably get it, right? But we kind of leave it up to the patient. But if I opted in and insurance was buying into this and you didn't have to pay out of pocket, these little MRIs, multi-parametric MRI, is what you can do to look to see if there's bumpiness, right? It's a great way to assess if someone has a a prostate cancer, and whether it's like benign or malignant. So is it growing or not? Is it using a lot of energy to reproduce its cells? Right, so what is this? It's BPH.
We're now back at the hour. This is DJ Easy Gleason. Well, I got a new one for you. This one is dedicated to all the men that are 55 or older, or if you're 40 and 45 high risk. This is Dr. DRE, or Dr. Digital Rectal Examination, with his 3-minute nothing but screening, coming from his latest album, The Chronic Condition. Bring it away! Yo, prostate check up 1, 2, 3, and to the 5. PSA not specific for malignancy anymore. Ready to make an entrance, so please this road. Gonna check that posterior lobe. Give me the lubricant first, enter up to my level. Prostate smooth as an eraser, and you aren't in trouble. Say nothing on a screen, baby. Starting at 55 years, maybe. Blue cross and blue shield is who pays me. This is the best we got, so please don't try to delay this. Hell.
All right, so yeah, the screening is like 45 usually is when we'll start it, especially if you have a family history or African American, because they're more at risk for prostate cancer. But earlier maybe or later, it's really based on your history, right? And what other guidelines have come out recently, okay? So that's the idea behind PSAs, right? And again, when it gets hairy, when it's in the 4 to 10 range. All right, so when you do that DRE, right, this is you want to make sure that you are using a lubricated finger, and we are assessing what kind of status, if they have prostate cancer. You got bumpy.
Okay, so just relax. Okay, it's not gonna hurt. All right, it's good. It's good. Okay, this is good. Good job.
All right, so all the treatments that we do for prostate cancer are going to cause incontinence and erectile dysfunction and impotence, right? So radiation could be an option. We do radiation to try to reduce the size and kill the cells that are growing rapidly. We can do external beam radiation where we just beam it. They might get little tattoos. They may be in the same spot every time and reduce the size, hopefully, and hopefully reduce the symptoms, right? And it's 5 times a week for 5 to 8 weeks. It's pretty involved, right? The other option is brachytherapy. And like if you see the doctor coming in the room with this device right here, right? It looks like a potato peeler, right? But what they're going to do is like, okay, sir, you're going to have to, get up in these stirrups right here, and they're going to literally nail you like 20 times, right? That's a real picture for our guest in the back over there, right? So we got 20 different needles that are injecting these little thin rods of isotope that will hopefully, we put like hundreds of, or I'm not sure how many exactly, probably 20 to 50 different little deposits of radioactive material that hopefully will stop the prostate from growing further, right? So that's called brachytherapy, where you deposit it, and you're not going to return. So these are not going to be removed at any time. These stay in place, and they have a half-life of like 500,000 years. No, I'm kidding. No, they have a half-life of a certain amount of time, and then they just stay in place. So the advice you give them is to make sure that they are, for 2 weeks, they're not having sex, and they are going to be impotent anyways, right? Those sperm are going to all get fried, but they should be wearing a condom for those first 2 weeks and 2 weeks more, and then at that point, usually the brachytherapy has resolved, right? But it has to be painful. All right, so surgery, they can do surgery, like I mentioned, prostatectomy. This can be for like really, really advanced BPH, but for prostate cancer, we have to resect the whole deal to try to take out all the cancerous tissue, all the tumor, right? So what they do is they just, if you've ever edited something, a video, and you cut out the middle parts, that's all you're doing is cut out the prostate and sew it back together, right? So here's before with the prostate, and here it's been cut out, right? Nobody knows that you tripped and fell. All right, so that's the idea behind a prostatectomy, and you're taking out the whole deal, right? They're not going to be shooting sperm anymore. They're definitely going to be impotent. Erectile dysfunction, you're taking a lot of nerves there, so you're high risk right? And the options are they go through the bladder, right? So they go through the top of the bladder and they rip open the bladder and they go in there, they scoop out the prostate and then sew it back together to the pieces underneath. Or they can take the approach that our brachytherapy physician did and they go through the perineum and they yoink out the prostate. That's a good video I should put there. You see the video of the guy that yoinks all the things in the Everglades? Anyways, so you have the radical prostatectomy. Obviously, it's radical. Okay.
Brachytherapy, those acupuncture like needle-like type things, the pellets are on the end of them and they pull out the glue.
Yeah, they go all the way in through the perineum into the prostate and they deposit it.
And they pull out those porcupine things.
Yeah, I don't think they go home with that. Okay. All right, so we have medications we can give. Depends on the cancer. Some cancers respond to androgens, right? It's an overproduction of the androgens. Remember, DHT is what stimulates overgrowth of those cells, right? And our whole point before was to give PO anti-steroid medications, right? Like finasteride, right? It stops the conversion to DHT so that we can then stop the overgrowth of our prostate. It's a similar situation. Some cancers are hormonal and we want to stop the hormones from even attaching to those androgen receptors, right? So DHT attaches to androgen receptors, but also testosterone does. So we are going to completely obliterate their testosterone. So we're doing androgen deprivation therapy, right? ADT, right? Are your home safe, right? So ADT is therapy where you're stopping steroid production altogether, right? So we can stop it up in, remember the gonads of the brain is your pituitary gland right there, right? So pituitary gland can shut it down by stopping FSH and LH. FSH and LH are the stimulus for testosterone production, right? So these are our guys right here. All right, Lopurolide, Degerlix, these guys are used to stop at the top, stop the production, stop the stimulus altogether. Sometimes that doesn't work and we have to then give this enzyme that we highlighted before, right? CYP17, right? There's literally 17 steps to make steroids. It's ridiculous. But one of the final steps is making testosterone, right? And it's not even called testosterone, it's DHEA, but we're stopping this production, therefore we don't get testosterone made, right? You can have all the FSH, LH in the world, but we're going to stop the production of testosterone altogether. You're going to stop it at the exits, right? But the problem is you stop everything in the cortex. You stop the mineralocorticoids, right? You stop the corticosteroids. And then, of course, you stop the testosterone, which was our point. But you have to replace the hormones that are missing. You have to replace the aldosterone and replace the steroids. Otherwise, you get endocrine complications, right? Which are Addison's disease is you need to add steroids to fix it. So you lack steroids in Addison's disease, so they can develop that if someone gets this therapy, right? So they have to be aware if they have abiraterone to obliterate the production of testosterone, then we have to replace steroids, right? The glucocorticoids, right? Like what's an example of a glucocorticoid? Like meth, right? You gave it all the time, right? Methylprednisolone, right? And if they're taking PO, usually it'd be like prednisone. Okay. The last option is to stop the down here. We're stopping the receptor sites. So testosterone might get made, but we're going to stop it right at the receptors on the prostate itself, and we're going to just inhibit the receptor, so testosterone has no effect, and therefore the tissue does not grow. Okay. And then chemotherapy, docetaxel is a chemotherapy of choice for prostate cancer, and it's usually someone that's not this is their pathway, their course with prostate cancer. Usually chemotherapy is at the end after we already tried ADT right here, right? So that's the plan or the treatment for prostate cancer. All right, so testicular cancer. All right, so testicular cancer, you can have other problems with the testes that we're not going to really get into. You should touch on these in peds some, right, where you have like a hydrocele, a fluid collection. You had a varicocele, the veins behind the testes are all dilated. You have a cyst that can develop, but we're talking about cancer today. Testicular cancer is the disease process we're focusing on and will be tested on, right? So testicular cancer is a mass that's developing, and there's different types, different cell lines that can get can overgrow, right? And how do you test to see if you have any of these things, but especially cancer? How do you assess that? What do we teach the patient? Is a testicular self-exam, right? So you have to do a testicular self-exam because it usually hits males, obviously, between in their 20s, right? Early 20s to late 20s. So testicular self-exam is important.
Oh yeah, it's Men's Health Awareness Month. Okay. When was the last time you examined your testicles, Bill? What? I don't know. Bill, testicular cancer is the most common cancer among men between the ages of 20 and 40. Okay. All I ask is that once a month you gently roll your testicles between your fingers, paying careful attention to the size, shape, and contour. Yeah, okay, I'll examine my testicles. Can I give you a consult now? Hey, is that Bill I hear? Yeah, Bill's here. Did you tell him to examine his testicles? Oh yeah, I just told him. Yeah, tell him to do it after he gets out of the shower when his scrotum is soft and relaxed. Oh, good point. Bill, you want to do it? Yeah, I heard him. I'm right here. Much easier with a relaxed scrotum, Bill. Yeah, okay. Thank you, sir. Hey, is that Bill? Yeah, Bill's here. Did you tell him about his testicles? Yeah, we told him. And tell him it's normal for one to hang lower than the other. Bill, it's normal for one to hang down lower than the other. Yeah, I know. Thanks. It's the right one for me. It's the right one for him. Oh, interesting. It's the left one for me. What is happening?
All right, so TSE. All right, so testicular cancer is the most common cancer in young men, right? And cure rates of 95%. Even if it's metastasized, it has a great cure rate, right? So we can discover it early and obliterate it, or we discover it late and it's metastasized, we can give chemotherapy and it gets destroyed also. So it's a unique in that manner, okay? So risk factors though. Yep, I did it. Okay, there we go. All right, so genetics plays a risk factor. If your brother has it, your father has it, it puts you up to a 10 times risk of getting testicular cancer. The highest thing besides genetics is cryptorchidism. So that's where an undescended testy, right? So if they have an undescended testy, that's really, really high risk for testicular cancer. Downs puts you at risk. Testicular dysgenesis, we have impaired growth of your testes, puts you at risk for your testes to overgrow, ironically. Okay, so it's abnormal overproduction of testicular cells. Right, you have germ cells, which divide into anything, including sperm, right? But also they divide into the other endocrine cells in the testes. We have Leydig cells and Sertoli cells in there that can overgrow, right? So Leydig ones are the ones that make testosterone, and obviously you can have too much testosterone. So someone that has like big genitals, it's like, well, shoot, you might have testicular cancer because they're overproducing testes. Okay, and then what else? So Sertoli cells are the ones that are making your sperm, and that can your sperm factory 1,500 per second. It's crazy, right? Your RBCs have that in the bag because they're 2 million every second. But we have germ cell tumors and we have non-germ cell tumors. So those ones of those specific cells usually don't metastasize. They're usually not benign. That's only 5%. The ones that overgrow are the germ cell itself. The germ cell starts making its own cell and it's overproducing, and it's growing rapidly, right? And seminoma versus non-seminoma, that's just based on the type. We're not going to test you on which one's which and identify it on a lab slide. But these are just to recognize that we have these cells grow super fast, and we want to make sure we are catching it early if possible. Okay. So doing a routine testicular self-exam is important. Let's see here.
No, there is nothing funny about testicles, Cooper, as you'll discover tomorrow in my office.
What? Sorry, sir, that sounds a bit weird.
No, it didn't. See me tomorrow.
All right, so testicular self-exams are important to detect testicular cancer. All right, so symptoms and diagnostic tests and how do you fix it? So it's a painless mass, right? Just like most cancers are usually painless, and it's not acute pain, right? Sorry, so not an acute mass that develops quickly. That might be like a cyst or something to that effect that we talked about, right? But it's a tumor that's growing. It usually grows slowly, and it takes time to grow, and we can detect it with our testicular self-exams, right? It can get really, really big and start compressing nearby structures, causing dull abdominal pain, heaviness, right? And this characteristic of the mass is it can swell, of course, redness. It's very hard, and then also if he's trying to flashlight through it, you can see through it, right? So it's called an illumination test, where you illuminate the testes, right? If you see something there, they have something in the way, right? Could be testicular cancer, right? And then of course you have to palpate it to look. But this right here is a negative, right? A negative transillumination test, right? So right here, what's his name? Hans? What's his name? Anyways, he does not have testicular cancer. Good job. Flynn Rider does not have cancer. All right, so you illuminate the testes and they are then clear, or the light goes all the way through. You don't have testicular cancer. Okay. All right, so for tumors, I mean, there's if they have testosterone overproduction, like we mentioned, they have prominent genitalia, they have early onset puberty, right? If they could have estrogen overproduction, that they can switch gears, right, and have gynecomastia, underdeveloped genitalia. But metastasis is a concern, right? It could go to the lung, and go to the brain, and then go to the bone, right? And you have symptoms of each one of those things. They're going to be short of breath with like pleural effusions for the lung. They're going to be confused and have seizures because it went to the brain. Okay, it goes to the bone. They have back pain. And why do you think that back pain happened? What's that oncological emergency that might be brewing? It could be cauda equina. Maybe compression fracture might have preceded it, right? All right, so an ultrasound, if they do find stuff on testicular self-exam, they do an ultrasound to differentiate it and to see if it's just a hernia. Is there a bowel in the testes? Do you hear bowel sounds in the testes? You probably have a hernia, right? That's a way to determine to differentiate it. Okay. And labs, AFP can be elevated. That's your alpha fetoprotein. That's also elevated in which cancer? Which gastric cancer? And liver cancer, right? Or I should show which GI cancer. And gastric is not the right one. All right. HCG will be like with their estrogen forming cancers. And then LDH is just high cell turnover, right? We see that in what syndrome? What oncologic emergency has LDH elevation also? Tumor lysis does, right? All right, so TSC monthly, we mentioned already, and they can do a rapid inguinal orchiectomy, right? So they can take out the tumor if it's invasive and it's growing, and certain tumors are invasive. Otherwise, if it's metastasized, we might have to do chemo and radiation. Again, there's a 95% cure rate when we do give chemotherapy, right? So at first, the lymph nodes will get involved around it, and the lymph nodes can cause mass effect, just like non-Hodgkin's. But again, it can metastasize to the brain, the lung, and the bone. All right, so what else on that? So before they get an orchiectomy, before they cut out the testes, right, they just take the testes out and they just snip it, right? And it used to, I guess it looked like an orchid to somebody, so that's why they called it an orchiectomy, right? They take out the orchid and they snip it, right? They just cut it out. And what does it say about that? So they can, if they're young in their 20s, they can bank their sperm. It's about $300 a year. I looked it up, right? So they have a ability to preserve sperm, and then at a later time, they can then inseminate someone with it, okay? All right, so that's our testicular cancer. Let's look here.
This is how to play with your balls so you can check for lumps. Number 1, have a feel during a hot shower. When it's cold, the dartos muscle in the scrotum contracts, making it hard to have a feel of the crown jewels. But when it's hot, this muscle relaxes, allowing you to have a better feel of the flesh marbles. Number 2, examine at least once a month so you know what's normal. When you have a feel at the top and back of the testicle, you'll probably feel a lump. This is the epididymis, the tube that transports sperm. Number 3, know it's completely normal for both testicles to be different. Usually the right hangs lower than the left, and usually the left is bigger than the right. Number 4, if you notice any lumps or swelling, even if it's painless, get it checked out.
Okay. That's the end, right? So that's the resolution phase is and we can sleep now.
Evening TV.